For those of you who are working on that in-basket that you are not loving, that you are hating the in-basket, remember to check out backlogbuddies.com, which is a co-working virtual platform where you can come and do your inbox and backlog work alongside other physicians and clinicians. This is your space to get your inbox done with friends. We know that backlog is boring. Backlog takes a lot of effort to overcome procrastination. It's not the fun part. And all of the physicians and clinicians who come into my world arrive with a backlog. And we know that some weeks we have big weeks and we have a little left over. So if you are looking for the perfect place to get your work done, check out Backlog Buddies. Hey, I'm Sarah Smith, family doctor, clinical day advisor, and the chatting coach. Welcome back to Sustainable Clinical Medicine podcast, where we're going to be interviewing peers or world experts who can help us think about our clinical day in a way that is more sustainable and create time for our lives outside of medicine. Hello and welcome back, everybody. Today we have with us friend and co-worker Sue Peters coming back to the podcast. I'm so excited for this conversation. I always learn something from Sue, and she's just been an amazing addition to our members, and we have her coming back for a workshop to our members as well. Welcome, Sue.
Thank you so much, Sarah. I'm delighted to be back.
Yeah, it's so good to have you. All right, let's let you introduce yourself, what you do in the world, so that we can just be reminded of those things.
For sure. I'm calling myself a healthcare improvement leader. And I'm originally an audiologist. So I worked with really deaf or very hearing impaired preschoolers. And then I eventually worked for a class 3 medical device manufacturer. And that's where I became really fascinated with quality improvement. And how can we work together as teams to help make change? And that's what I've been doing for many years for lots of different clients. It's all about trying to make patient care better and improving the lives of our patients, but also at the same time improving the lives of our providers.
Yeah, I love that. And when we talk about teams, when I talk about team members and making strong teams with my members, typically they're not got the hire and fire capacity within the organization. They're really given a team to work with, and that's that. And they have to try and make the most of it, often without any formal training on how do we communicate with a team, how do we move together towards a goal, and all of these expected leadership skills that we are supposed to find on our own because of the role that often the members are in, which is in that decision maker role with regards to patient care or patient decision making, clinical decision making. So you move into this special space of trying to get both sides. I call them sides because they're often butting heads when you meet them.
Great. Yeah, for sure. And there is always that tension on how do we provide good patient care, and then how do we also meet the needs of the program and things. So let me just give you an example. I've been working with some specialty teams recently, and what I find with some of these teams is that their access is very poor. They have very long waiting lists. And so it's working with the organization and working with the team members to look at, who are we providing services for? Are we doing things like filling prescriptions for patients that may no longer be ours? Or we're filling prescriptions for things that really aren't this specialist specific and really should be going to primary care. And so every time specialty tries to fit the gap for primary care, which is the specialty in itself, when we say yes to that person to fill a prescription that really should be filled in primary care, we're saying no to someone who really needs our services. And so how do we really focus on that? And so one team I was just working with recently was looking at prescriptions and how they're managed by the team. And so the specialists would come in and they face a stack of charts that had all of these prescriptions, and when they went through them, actually they were not things that they needed to fill, or they were actually not members of their service anymore. And so we streamlined their process so that other team members are helping to get patients to the right places, and that only when a prescription needs to be prescribed in between two specialty appointments, that's when the specialist would see it, right? So it's freed them up a lot of time, rather than going through this stack of 10 charts to realize actually only 2 of them needed that prescription. Using team and allowing them to do the things that they're highly trained for, and helping people that need their services.
Yeah, that's a great example right there. I think that coordination of what is the physician's job, what is the not physician work that they're doing, and how do we offload some of that to the team in a responsible way so that the
100%.
person, the patient, can get the care that they need from the right place the first time.
Yeah, exactly. And prescriptions renewals also in primary care too, is that we get lots of requests that are coming in electronically from pharmacies, and often if they don't hear from us in a couple of days, they're sending it again and again and again. And that is not physician work to be going through those prescriptions. That is teamwork. It is teamwork to look at what is being prescribed, to transcribe what is being prescribed or asked for the renewal, and then ensuring that any testing that would be required at that time is actually getting done, so that when that prescription renewal, it's all ready to go. Of course, the physician has to be reviewing it, make sure that it's correct, and then hitting send to set that prescription renewal. Yeah.
Yeah, just different ways to work on flow. I know that we have access issues across every country probably right now. I was specifically really difficult to get people into primary care, which may then further compound what's happening in the specialist, the non-primary care specialist fields. But we also are seeing an aging and more chronic disease population, where if we don't hand these stable chronic disease patients back to primary care, then the specialist is going to be overwhelmed with new requests and ongoing following of these patients. I know that that can really slow up things in terms of getting patients into the specialist.
Absolutely. And so we want to unpack everybody's backpack. So physicians who are doing things that are not physician work, how do we justify other team members that can help support that work? So we want to be really thinking about what are all the things that I'm doing in a day that actually could be done by someone else. And it might be the RN is taking over, if you have an RN available to you, managing patients with chronic disease. But what are the RNs doing that they actually don't need to be done and doing? And could it be done by an LPN, a licensed practical nurse, or could it be done by a medical office assistant with a script, as long as they're following the script? Do we need to have us call everybody with a result? Like we want to be calling patients with positive or negative test results, but it's who does it is in Streamline. And lots of times patients don't have questions about that. And if they do have a question, I'm going to put you on hold and I'm going to grab one of our team members and they will be able to answer that question for you. So it's all about how you divvy up the work. And what my goal is when I'm working with teams is to make every single team member feel like they are critical in the care of patients. Because lots of times when MOAs who are booking patients, they know so much about patients. They know a lot about patients. They know that Mrs. Brown sounded one way last week, and then when she called this time, she didn't sound like she did last week. And they can be so critical in saying, you know what, I'm worried about Mrs. Brown. I think we need to see her because she didn't sound like she did before. And it's making every single person having a critical role. And that's how you get a team to stay with you, right? Because they love the job, because they feel important. And that's what my goal is to get everyone on the team working to top of scope.
Mm-hmm. Yeah. And taking things out of their backpack. I really like that analogy because our team members are already busy. We've all filled up our days. It's just what did we fill up our days with? And how can we do
Exactly.
less of the things we don't need to do? How can we streamline processes or use some of the other ways of managing this big amount of work? What are some of the other things you've done together within that space of a team that maybe some other ways we can divvy up the work? Any other examples you've got there?
Yeah, so I've been working with a team recently who was looking at the way they onboard patients, because everyone is trying to look at how do we expand the capacity in a team to be able to onboard new patients, right? And they developed a whole way of onboarding patients, because often what we see is teams have that meet and greet appointment, and they're very special, and they take a long time to book because you can't have them a lot of them. And what I see is physicians using those meet and greets and populating the EMR for those meet and greets. And that I see as not physician work. Yes, you want to have to meet with the patient, you want to develop rapport, you want to develop that really critical relationship with the patient, but you don't need to be putting information into the EMR. That's teamwork. And so what this team did is when they were receiving a new patient, they would have a licensed practical nurse call the patient, and they would first of all mine all of the information systems that were available to them, and putting the medical surgical history into the EMR in a consistent manner, and then talking to the patient and further populating their medical surgical history, and then saying, going through their screening, for example, so I see you haven't had cervical cancer screening recently. Let's book you in for that. And that's not necessarily with a provider, right? It could be with another team member who's doing that. And so what they do is they offer everything that the patient needs, and then that initial appointment happens when the patient needs it. So it might be that they are, really struggling with their diabetes and they do need to see a provider, that appointment with the provider is just in time. Right. And so sometimes when this physician assumes responsibility for the care of a patient, because of the team is helping to look after the patient, they may not see them for 6 months until something triggers a provider appointment.
Interesting, interesting. I've just moved country, so I'm now in Australia, and I've had to meet with my new team. Okay, you got to go to the doctor occasionally. And it's interesting seeing the process of that information is collected on paper as you arrive, And then when you go in to see your doctor, it hasn't yet been updated to the EMR. They don't even get to see the piece of paper, which I just spent time filling out. There is definitely opportunity to email me ahead of time. I'm very savvy. I can fill in a form.
Great.
And noticing the whole information collection happens again, because they can't do anything for you until they understand who you are, what you do, what you're on, all the things, right? And so we know this as physicians, as clinicians, we know that we need this background information in order to do our job. However, the whole process was almost backwards. That should have been sent to me as I made the initial appointment, somebody updating it before I arrive. Yeah.
Right. And you know, it's been interesting because I've recently been working with an organization where we were implementing patient medical home. And it was very interesting to me because a lot of the physicians were sole providers. And so they had their practice, they might have had an MOA who was doing booking for them, and they might have had part of an LPN who was doing blood draws for them, for instance. But everything else, they were doing it alone. And they all came onto a provincial EMR at different times. And it was just so interesting to see how differently all of the EMRs are populated. And by and large, no one really had every single med surgical history updated. And then when you have to send someone to a specialty and make that referral, and it's like, I don't have all my medical surgical history here. And it's so much easier to do it. If everything is populated, it's super, super quick. And so I know, Sarah, when you talk about let's do today's work today, you know, those are the patients that it's like, oh, I don't have time to do that because I actually have to populate everything. And that's when work gets batched for the evening, work gets batched for the weekend, and it just hangs over you. And a lot of it is because the medical surgical history is populated.
Yeah, yeah. I know we've spoken in the past about optimizing that EMR, optimizing the electronic medical records so that it works for you and it takes
Right.
less it takes less time within the appointment if things are done well with information going in and optimizing that electronic medical record. Anything on the horizon at the moment or that you've been doing with teams to help optimize the flow so it does take less of the people work to get the information in and out of this big computer program?
Yeah, it's such a big thing about, you know, how you're using the EMR. And what often I see even in practices that are sharing an EMR is that everyone is doing their own thing in different ways, right? And so let's say that I have a team member who's working with me on a regular basis, and when that team member is missing, it's like, oh no, you know, everything falls apart. But if we're actually work together and help develop processes that we can all live with, they may not be exactly how I've done things in the past, but if we can work together and agree on how we're populating the EMR, how we are inviting other team members into the care of a patient, like social work. And if we're all doing that consistently, then it doesn't matter which team member I happen to be working with today, that someone else could be filling in, and we do things exactly the same. So for example, we don't want to dictate what your schedule looks like, right? You know, you may decide that you like to spend the first hour returning phone calls. Like that's just something that you like to do in the morning. But what if in the EMR we put a template together and agreed that, you know, this color template refers to telephone appointments, and this refers to virtual appointments. And you can schedule however you want as an individual, but that across the practice, this is going to mean the same thing. So if you have someone else booking your appointments, they can see in the schedule that that's where Sarah wants her driver's medicals, for example, or, you know, certain things, or your telephone appointments or your virtual appointments. And so it's about adopting things in order to all of us kind of working similarly and consistently, and how we're populating the EMR, how we're using the EMR to pull reports to say, you know, where are all of our patients with diabetes? Who are the patients that haven't had a foot exam in the past year? Let's get this med secretary or medical office assistant calling those patients and booking them in with a team member to do that. And so the more consistently we put information into the EMR, it's easier to pull information and pull lists that we can have other team members action for us, right?
Yeah.
Yeah.
I know this is important, but we know it's important for patient quality care, right? To be able to say, you know, who of my diabetics is currently up to date with all of the things they need for this period of time. We know this as physicians and clinicians. We also know it's tied to bonuses for many of the payment models that physicians are working within or organizations are working within. And therefore, there's additional reason to want to make sure that you've done the ticker boxes for each of the types of patients that you have. And still, even with bonuses attached to it, still I see the doctors doing it in every visit, every time with their patient. Oh, is your HbA1c up to date? Oh, have I done a foot check in the last year? Oh, this, oh, that. And then now scanning through rabbit hole of the EMR, looking for those things. Have I done it? Have I done it? Have I done it? And therefore, can I report it? So have I ticked the right box? This is not physician and not clinician work. This is part of that team process that, as it's done, if it turns up in the right section of the EMR, you can pull that list and you can tell who's on and who's off the list.
Right. And you know, one of the things that I suggest to primary care physicians to actually start delving into panel management is to run a report of all of the patients that you have on your caseload, if it's a typical caseload, that have diabetes. And if it's 5%, then it's probably wrong, that it probably not all of your patients with diabetes actually have the diagnostic code that represents diabetes in the EMR. And so that is so critical. Who is putting those in, those critical diagnostic codes, so that we can then pull reports and registries of patients, all of our patients who have COPD, who hasn't had a COPD action plan done in the last year. And again, that's not physician work. And I would argue that the only time you should be seeing a diabetes patient as a provider is when they need to see a physician. Right? They can be managed by other team members extremely well. And we're so used to seeing those patients 4 times a year, whether they need it or not, just because we're worried about them falling through the cracks. And the best way that we can prevent patients from falling through the crack is embracing our team and panel management to help us to ensure that we are providing all the care that we can for our patients.
Yeah. I want to add that it also reduces the mental load on you and the worry that you have for your patients when you know that your patients are being looked after on your behalf. So when you think, oh, you suddenly have this remembering of, I haven't seen that patient for, oh gosh, how long's it been? And now you're digging in the chart to see, have I seen them recently? Are they due for something? Because I know that they're one of my important and critically unwell patients. And you're relying on them booking in and making sure that they're coming in, or you've left yourself reminder notes all over the place so that you don't forget to call them. That's part of the mental load that will burn you out.
Exactly. Yeah, for sure. And you know, and these providers are busy, like their physicians are busy seeing the patients that are coming in, but what are the patients that aren't presenting to us? And what panel management and team-based care allows us to do is look after all of our patients, whether that is a caseload of patients in the terms of specialty or a panel in the case of primary care. And being able to find those patients that aren't necessarily presenting themselves and reaching out and grabbing them and inviting them in to receive care. That's what it's about. Yeah.
Mm-hmm. Yeah, absolutely. Not just waiting for them to be in front of us. When they do finally come in front of us, often they're there with so many other problems that we don't even get to the things that they potentially do for as well. So yeah, or we're adding that to the visit, which is adding to the visit time. So
Right. Yeah, exactly.
yeah,
Exactly.
yeah. Now, what about team members who don't want to cooperate with us?
Yeah, oh no, this is a really good point. I'm working with a new team, and what I hear them say right now is, you know, they are team-based care specialists. That's what they do, is helping teams, but they saying, it's really hard to get everyone together and on the same page. And so we'll get invited into a clinic and we'll be, working with the physicians. And then when we go talk to the other team members, they may not see things the same way. Or they might have a clinic manager who's been doing things in a certain way for the last 15 years and are not open to this change. And that happens all the time. And so what we need to do is get together. And this is what I'm going to be talking about, is to actually do quality improvement. And the first thing on the sequence to achieve change is to form a team, right? And we need to have team members, like everyone, all roles in the clinic represented in that quality improvement team, because then you have all the voices at the table. You have the clinic manager, you have the medical office assistant, you have the LPN, you have the physician, and it's that opportunity for the physician to be providing engaged leadership, right? And so everyone, it's like, what is our aim? Like, what are we trying to achieve? And working together, because I might come up with some brilliant plan, but I won't have considered everyone else's perspective, and often it falls flat when it's implemented. We're very famous here in Canada for planning things, and then the implementation. We have beautiful plans, but then the implementation falls flat because we actually haven't co-designed it with the people who are actually doing the work. And so the people who are doing the work have to be involved in changing the work.
Yeah, yeah. And if you're trying to get perspective on this, just think about when rules are thrown down from the top at you and how comfortable or uncomfortable that is. You like to be made aware that change is coming. You like to be, if possible, part of the decision making, because if you're the one who's going to be implementing a new rule, it's not nice to have it thrown at you. And so being included at the table, having a voice or having somebody there advocating on your behalf is a much nicer way to receive the suggestion that you're going to be following a new rule or new set of standards or practices, requirements. This is the same with our team when we're working with these people who are there. Sometimes they're there to pick up a paycheck, but they're also engaged with our patients. And truly, if we can get on the same page with regards to that, we want to improve patient care. We want this all to run smoothly for everybody. And we're not just going to add things to your backpack. We're actually going to think about what's in your backpack and maybe take some things out of your backpack. Now we might have some improvement.
Yeah.
In the formation of a team.
Yeah, exactly. And unpacking the backpack, lots of things that we do are dictated by our patients. And we have to actually talk to our patients and ensure that what we're doing is evidence-based. right? I hear lots of like, oh, well, the patient's just used to having blood work done every year, but there's really no evidence to support it being done. When you say yes to that person, you're saying no to somebody else. So it may seem easier to do that blood work, but someone still has to draw that. There's resources associated with that. It has to be analyzed, resources associated with that. It has to come back and there has to be a decision made by someone on the team about the result of that blood work. And then there has to be communication with the patient. So it's actually, breaking patients' expectations of certain things that are not evidence-based, and we need to have those conversations, right? And it's not necessarily physician work to do that, it's teamwork. We need to have people at the front who are answering the phone with a script for that scenario, right? And invite them to speak with another team member if they need more of an explanation. But there's lots of times we do things just because the patients ask, and it's not really in the best interest of the entire panel for us to be spending time on that.
Yeah. Okay. So this is more thinking about your whole population of patients, and then the number that keep returning to you that don't necessarily need that seat at the time, so that you can free up the seat for the other members who do need to be on that seat at that time. Is very interesting, more broad thinking work that we'll be doing within the workshop with you, and just to have a different perspective and shift in how we're working, because you're right. Often we turn up and we see the patients who book themselves in for today, and then we turn up tomorrow, we book the patients that book themselves in for today, and we're only doing the opportunistic always, without thinking about who needed this appointment and how did I make provision for them. Oof, that's big thinking, Sue.
Yeah, and what is actually the need of the patient who keeps booking in every week? It may be because they're lonely. And so they may need a different service from us, connecting them with community resources where they can get, because you're lovely to talk to. They really enjoy being in that space, but that's not a good use of an appointment. And how can we help the patient get to the care that they actually need? And it might be a community resource that is providing that.
Yeah, yeah. I love using team that's beyond the walls of the clinic. So beyond the people we're paying, who else is available for this patient within our community, and looking out further than our walls to see who else is part of this patient's care. Yeah.
And Sarah, I talk about you a lot when I talk about how are we coordinating care in the health neighborhood and also in community agencies. And I always loved how you would sit down with your patients and do care planning and have that care planning being done in their own words. Like, I want to be able to walk my grandchildren to the park. That's what my goal is. And my hemoglobin A1C may not be the top of thing that's on my mind, but it may be what you're thinking of, and then inviting others to provide input into that care plan, and you sending it to all of the people that are involved in that patient's care, so that they can reinforce what they're talking with the patient about, and framing it in how they want to frame those goals. I just love that. I talk about you all the time. So,
well, having moved back to Australia now, I'm in general practice here, which is family medicine primary care for those of you who are, or family physician, those of you who are not in Australia. And that GP management plan and the health assessments here. So we do a health assessment on our over 75s, or for our Aboriginal and Torres Strait Islander patients every year, or every 9 months even. And we also do the chronic disease management plan. So anyone who's got a chronic disease that needs to have some sort of alternative provider. And there is even some government money for them having a visit with this physical therapist. one of the absolute keys to being compliant with those care plans is to develop SMART goals for your patients, and that must be in the patient's words. And it sounds like this: in the next 12 weeks, what do you want to do with what are you working on with your psychologist, or what are you working on with your physical therapist in the next 12 weeks? So it's not even like, what do you want to achieve? It's like, in the next 12 weeks, what do you want to achieve with your psychologist? And we talk about, I want to be able to leave the house to go to women's group once a week to do crafting with them. Oh, okay. So for them, the patient's identifying, that's a challenge for me. I can't get myself out of the house to that group on time. And so who do we need to put around you in order to get you there? Or and that's such a specific goal for the psychologist to work on with them.
Mm-hmm. Yeah, exactly.
So they know exactly where to start, which is it's so
Well,
good for patients.
And where it is that's started is you're asking what matters to them, you're listening to what matters, and you're doing what matters, right? And that's how we do better for our patients with chronic disease, is we solve the things that are troubling them, that really matter to them. And it may not be top of mind for us, but it's top of mind. We're not going to get them to worry about their own diabetes management if they are looking after someone in the home who has dementia, and they're worried about them wandering more. We have to actually deal with that first before they will look after themselves, right?
Yeah, such important work to do, and such important work. I remember we were evacuated from Edson for the wildfires, and the day of the evacuation, I was able to call the social worker for the homeless society in Edson and say, who's going to go pick up, or who's making sure that the homeless people on your list are being found. And she's like, I'm not even in the town right now. But good point. And so she rang the mayor, because she has him on her phone as well, and to check that somebody had thought about others in our community of most vulnerable, and they had a plan. And so we could all relax. But just being able to have walked the pavement to find out who's in our neighborhood who looks after our patients, and having them that ability to communicate with them is so valuable, because then patients could be I could be messaged by the social worker to say, so-and-so is running out of this, and if we don't keep them on that, then they're going to end up back in hospital. Boom, we get an appointment made for them right away. So it may not have been exactly right, her having my number, my having her number. It could have been a team member, but in this case, it was just the first step of how do we look after the patients and make sure that they're getting looked after, who else is seeing them. Yeah,
exactly. Yeah.
Great. Okay. Well, we are looking forward to your workshop, so we can learn all about making great teams and taking things out of our backpacks, which I think is of most importance given how much is in our backpack. Anything we didn't talk about that you want to mention before we close up today?
I guess no, I think we've touched on all the things that I really want to talk about. The only thing I would mention is about looking for the helpers. And there's lots of people out there whose job is to help support quality improvement, and they're called practice facilitators, they're called improvement advisors. And one of the things that I do is I help train those individuals, and those people have they look at everything through a quality improvement lens, and everywhere there are those people around, you just have to find them, and bringing those people into your team is really, really important. So I want people to be thinking about who are out there that can help me do this, because they exist out there. You just may not be leveraging their resources either. So yeah.
Good point. You don't have to invent the wheel here. There are people out there trained who can come and help your team.
Yeah,
so good.
and as practice facilitators and people helping teams, like, my goal is always building the capacity in the team, where I work myself out of a job. Like, that I want to see them grow their quality improvement muscle so that they could take any change that in the future and make it happen. And some of the teams that I have worked with recently, I just am so proud of them that they actually don't need me anymore, right? And I love that. So that is the thing that gives me the most joy, is watching a team just develop those skills and just carry on and do great things. It's so rewarding.
Yeah, love that. Thank you so much for coming. Thank you for being here.
Yeah, thanks, Sarah. It was so good to see you.
So good to see you too. All right. Bye, everyone.
Thank you for being part of the Sustainable Clinical Medicine podcast. If you'd like to learn more or join us to help you get home with today's work done, go to chartingcoach.ca. There you'll find all the information on the Premier Lifetime Access Charting Champions program that is helping physicians get home with today's work done, with all the proven tools, support, and community you need to create time for your life outside of medicine. We would love to see you there. Until next time, thanks for listening.